Kim Hunter Reed,
Here.
Secretary Robinson,
Present.
Dr. Katara Williams, Dr. Adrian Wilson, Dr. Victor Jones, Dr. Mary Meg Brown,
Here.
Dr. Renato Banks, Senator Regina Barrow, Dr. Terry Davis,
Here.
Dr. Rebecca G, Miss Tiffany Netters, Miss Carol Smith, Dr. Ronnie Whitfield,
Here.
Dr. Wilkes,
I'm here.
Dr. Ijigiri, Dr. Eric Van Home,
Here.
Ms. Deleso Alford, Dr. Tavell Kendall, Representative Dustin Miller.
I'm here.
Ms. Okay. Ms. Alma Stewart,
Present.
Mr. Christopher Tyson, Dr. Derek Rivarius, Dr. Corey Hebert, Ms. Lenore Carroll,
Here.
Dr. Keith Ferdinand, Councilwoman Helena Marino.
Sadie Finkel for Helena Moreno.
Okay, thank you. Councilwoman Cindy Nguyen, Dr. Alicia Bates,
Here.
Dr. Janine Thomas,
Here.
Dr. Leanne Fowler, Miss Cindy Snyder, Miss Kathleen Tate,
Here.
Dr. Lisa Van Hoos,
Here.
Miss Shalina Davis, Mr. Michael McClanahan, Dr. Connie Arnold,
Here.
Dr. Faye Grimsley,
Here.
Miss Erica Rogers, Mr. Frederick Thomas, Dr. Demetrius Porsche, Miss Judy Reese Morris,
I'm here.
Dr. Earl Benjamin Robinson, Dr. Peter Foss,
Hi, I'm good.
Dr. Kathleen Kennedy,
Here.
Dr. Robert Maupin, Dr. Christy Anderson,
Here.
Dr. Takesha Davis, Dr. Amanda Dumas,
I can call Silverback myself if he can call me in some.
Dr.
drops.
Amy Leston,
I got under the
I'm here.
shower, I put drops in my eye, and then I also.
You'll need to mute Dr. Davis.
And then I got under the shower and I let the water.
Flores, can you mute,
One of my
please?
basic scientists at the med school said, oh, don't put that water in it. So if he could call me in something, that'd be great. And I'll just call Silverblatt if it's still bad.
Flores, please mute.
Well, I'm on
mute
Zoom
her.
calls the rest of the afternoon.
It's muted.
And he doesn't work on Friday anyway, so I could call him myself.
Okay. Ebony, Dr. Ebony Price Haywood,
Here.
Dr. Margarita Echeverry, Miss Christian Engel, sorry. Miss Tina Granger, Miss Catherine Haywood, Reverend Theron Jackson.
Sorry, here is Margarita.
Yes, ma'am, I have you. Thank you. Mr. Rudy Macklin, Dr. Orlando McMeans,
Here.
Dr. Rhoda Reddix,
Here.
Dr. Rambati, Dr. Jacqueline Harris, Dr. Peter Kasmarsky,
I'm here.
Dr. Daniel Sarpong,
Present.
and our special guest, Dr. Joseph Cantor,
Yes, ma'am.
and Dr. Crucell Wood.
Here, thank you.
Thank you. That concludes the roll call. Did I miss anyone that joined the call after roll call?
Derek Roveras.
Okay,
And also Thomas Leviste.
I have you, Dr. Levy.
I knew you would.
Anyone else?
Yes,
Hey, I have you, Dr. Williams.
I heard you mention Dr. Victor Jones, but I don't know if that's me or not.
That's you.
Okay.
Yes, sir. That concludes my roll call, Dr. Williams.
Thank you so much, Ms. Gerald. Good afternoon, everybody. So good to see your faces here this afternoon for this very important work. As you know, we are still mitigating through the COVID-19 pandemic, and we have lots of work ahead of us. So today we have a couple of special presentations, some very informative presentations. We do want to invite everyone, for those of you who are listening in or watching in on the YouTube link, if you have public comments, we ask that you send those comments via email to us at public_comments@sus.edu. Again, that's public_comments@sus.edu. With that, we'll turn it over to our co-chairs, Dr. Leviste and Dr. Brown.
Thank you, Dr. Williams. Dr. Leviste, you with us?
I am here.
Hello, it's so good to see you and to see everyone. So we bring you greetings. We have a full agenda and we want to be respectful of everybody's time. So we'll start with the first item on our agenda, which is an update on the Louisiana Vaccine Action Collaborative. Unfortunately, Dr. Welsh is unable to be here with us today. He is recuperating at this time, but we are so fortunate to have Dr. Joe Cantor, MD, MPH, Interim Assistant Secretary and Assistant State Health Officer, to give us an update on the important work of the Louisiana Vaccine Action Collaborative. Dr. Cantor, welcome.
Thank you, Dr. Brown. Thank you, everyone, for inviting me to share with you. As I start, if I could ask permission to share my screen from, I think Mr. Wilson is listed as the host.
Yeah.
But also talking as we do. Dr. Welch is under the weather, as you mentioned, Dr. Brown, and we praying for a speedy recovery on his part. I know he had the honor of presenting to this group earlier, and I'll try and pick up on that. What I'd like to do is just give an overview of where we are with vaccine planning, what we know at this point, which is not a lot and changes quickly, and where we see this going forward, and maybe take 10 minutes of time doing that and save some time for questions if there are any. Before I do that, I do need to say we very clearly are in a different part of our pandemic right now. We are in the middle or the beginning stages of another increase or wave or surge, whatever people would like to term it. We're in it. We had the luxury of sitting back over the past few weeks and really watching almost every other state in the country experience increases and holding steady here. Luck has run out, and now we are increasing. We have every reason to think it will be as bad, if not worse, than our second big wave in July and August. We added over 250 hospitalized COVID patients to hospitals statewide in the past week. That's a rate of growth that's just simply unsustainable for hospitals here. So from our perspective, and I did want to lead with this, we consider this an all hands on deck effort. This is, we're in it, for lack of a better term. And with Thanksgiving coming up, I mean, the holidays just could not be at a more inopportune time. Really has the potential to throw fuel on fire. So my main ask, which I'll come back to at the end, is to ask everyone on this call to reach out to their own networks, their own institutions, and urge prudent behavior over the next couple of weeks because we think it can make a difference. Thank you for hearing me out on that. Try and share my screen here. Great. And so I'll run briefly where we are in the vaccine work. And I do want to thank, there's been a number of people on this call who have just been tremendously helpful, not only to the Vaccine Action Collaborative, but to the Department of Health in general, and pushing forward a message of mitigation measures and safety. So thank you for the partnership on that level. Before I go into this PowerPoint, a few overarching points. The vaccine distribution and allocation process will be a mission whose complexity I don't think we've seen the likes of here. An incredibly complex mission, multiple different types of vaccine, different handling instructions up to and including ultra cold storage, which is -60 to 80 degrees Celsius, different follow-up intervals. People that get one particular type will need that specific type or brand for the second dose if it's the brand that requires, if it's not the single dose variety, and a timeline that will be incredibly rushed. So it's an operation whose complexity we just have not seen the likes of before. I will say, as every day goes on, I have increasing confidence, not only in the process, but in this being the way out of this pandemic. I mean, the news that everyone has seen that's come out over the past week or two, both the two leading vaccine candidates, Pfizer, Moderna, are coming in at over 90% efficacy. Pfizer, as folks saw just today, formally applied for their FDA emergency use authorization. A couple months ago, we were saying that we would be excited about 50 to 60% efficacy. And to have these two candidates come in at 90 is very encouraging and clearly is the way out of this pandemic. The other thing that's been encouraging to me is I've received greater confidence in the transparency of this process. We've had assurances, both formal and public assurances, but also offline assurances from Stephen Hahn of the FDA and from Tony Fauci, multiple times offline from Tony Fauci, on the transparency that will come, on the independence of the data safety monitoring boards and the other regulatory facets in here. And he basically committed to us multiple times that the data will be made public and be made public quickly when FDA does give authorization of these products. So I'll tell you, I have a lot more confidence now than I did a couple months ago that the approval process will be not only appropriate, but transparent. Personally, I'm very happy about that. I know we have a lot of work to do, but I'll just tell you, it's becoming increasingly clear that the FDA and the NIH are taking this very seriously. Also have been assured that representation in trials from marginalized communities has improved. Quite frankly, it was abhorrent earlier. The pharmaceutical companies have worked hard. The Pfizer product in the latest report that I saw had 20% of trial enrollees of either Black or Latinx representation, which is significantly better than where they were at a couple months ago. I don't know numbers for the other candidates, but that's a welcome improvement, no question about that. And then as we go forth with the vaccine distribution, I mean, equity remains of paramount importance. I mean, this vaccine distribution plan has the potential to exacerbate the disparities we're already seeing with this pandemic, or to start bridging them. And certainly we hope for the latter. A couple of points, we're trying to learn as many lessons as we can from the experience of the H1N1 distribution plan, and some things went really well, and that one, some things went not so well, and we're learning from. One of the things that's interesting to note is sometimes all the planning you put in doesn't save you from last minute changes. And in H1N1, we had a good plan for distribution. We had a good sense of who was going to get the initial allotments. And when the very first product became available to us, it was recommended specifically for pediatric patients, which was not our intended initial allotment. So all that to say, we're doing the best job we can to plan, but the key unknowns of how much we're going to get, what type we're going to get, when we're going to get that, are still unknowns to us. And we're doing the best job to do mitigation planning and contingency planning, but at the end of the day, we'll need to respond quickly to whatever it is that is made available to us. We do believe that the initial allotment will likely be the Pfizer product, will likely go to frontline hospital personnel, try very hard to consider who it is in a hospital that is on the front lines being exposed to COVID. And it's certainly not just the licensed professional staff. So very thoughtful about terminology that we're talking about personnel. We're not talking about doctors and nurses. We're talking about support staff and everyone else that puts on the front lines. Although it will be most likely quite limited. The complexity of that Pfizer vaccine, the ultra cold storage handling, makes it impractical at the moment for non-hospital entities to really manage it. So those first doses likely will go to hospitals for frontline personnel. After that, commercial pharmacies will play a larger role, and the public health apparatus will play a larger role in dissemination. Walgreens and CVS have already signed contracts with federal partners to do two things. Number one, to go into nursing homes and other adult residential facilities and vaccinate on site. And then following that, to provide general public vaccination within their stores, which would be a good capacity builder for us. We're expecting essentially a 1.46 pro rata allocation of whatever number of doses are made available initially on the federal level. We're expecting about 1.4, 1.5% of those to come to Louisiana. That larger number keeps changing. At one point, there were expected to be 20 million doses initially available initially. Last number we heard was 7 or 8 million doses. So I don't know what the overall number will be, but we do expect about 1.4, 1.5% of those to come to us. Again, we think Pfizer, the product, is going to be the first one that's made available. As I mentioned before, these products are not interchangeable. So an individual that gets a particular dose, so they get the Pfizer product for the first dose, will need that product for the second dose. Right now, there's only one vaccine candidate that's a single dose series. That's the Johnson & Johnson one, which is not the farthest along in trials as some of the other ones are. There will remain unanswered questions, I think, when the first allocation comes out. Specific efficacy by age group, I don't expect to know. Performance in children, safety for pregnancy, lactating women, we don't expect to know within the first allocation. We expect to get some data on that a little bit later on in the process. How long it takes from the time someone gets their second dose to the time they have protection probably will be relatively unknown as well. We do expect these products to have emergency use authorization, not full FDA approval, but we also expect much more data to be made available publicly than would typically happen in an EUA process. What the feds have been doing here is they've been paying the vaccine manufacturers to produce at scale the product ahead of authorization. We don't feel that that skirts the regulatory pathway or does anything to shortcut safety, but it will, when approval is granted or authorization, essentially have a head start on production. So all that to say, FDA is expected to give EUA rather quickly to the Pfizer product. And once they do, it will start shipping. So things would happen quite quickly after that. We think it will be safe to vaccinate after prior infection, although perhaps not prioritized. And the feds will supply us with most of the equipment needed, syringes, needles, and so forth. Some parts of it, gloves, sharps containers, bandages, will be on us or the administering entity to provide. This is a rough schematic of what the different phases of the vaccine rollout we'll likely look at. Phase 1 is divided into 2 phases, phase 1A and 1B. 1A, again, is very limited volume, likely less than 1 million doses for high risk frontline hospital personnel. Phase B extends that to the highest risk patient individuals, likely adults living in residential care facilities and nursing homes. Phase 2 expands that to essential industry, critical risk workers. That certainly includes teachers and other school staff, and a larger segment of people that have comorbid conditions that put them at higher risk. Phase 3 extends that to additional essential workers. And then phase 4 is general population. This is a draft schematic. Eventually this gets approved by the governor, and ultimately each governor has authority over how the very limited initial doses get allocated in their state. Quick scenario of what this might look like. We've been trying to plan different scenarios based on which product we'll get. So what the CDC has suggested we call scenario 1, which essentially is the Pfizer product that likely is going to be first, 2-dose series separated by 21 days, shipped ultra cold, which is high complexity supply chain issues to deal with. And then it has really challenging storage requirements beyond there. It can be stored at refrigerator temperatures 2 to 8 degrees Celsius for up to 5 days. After that, when it gets thawed, it can stay for 48 hours. It gets added with a diluent, and after that, it's stable for only 6 hours. We've never seen a vaccine that's this fragile before. So it adds to the complexity, and it limits what type of entities are going to be equipped to handle and work with a vaccine of this fragility. Scenario B, which is the Moderna scenario, really would be 2 doses separated by 28 days. It has more reasonable storage requirements, frozen or refrigerated, use within 7 days, and then after taken out of refrigeration, it's good for 12 hours. That's a little bit more reasonable. That's the type of product that likely would be used outside of a hospital setting, in a nursing home, in a clinic, and so forth. So give an idea of what these products actually look like. This is what the Pfizer product looks like. It comes in a vial. There, after you dilute that vial down, it makes 5 doses. Those vials get packed into, I'm looking at frame number 2 there, get packed into what the company is calling a pizza tray, but it's 975 doses packed with dry ice, folded up like a pizza box. And that's how it gets shipped. And go over to frame 3, and they'll stack a number of those pizza boxes into a crate, fill it with more dry ice, and send it out. This actually adds another layer of complexity because the smallest amount of dose that gets shipped, the smallest allotment, is 975 doses. And it's hard to ship to sub-distribute smaller doses next. It needs to be repacked in dry ice. So it does limit how far it goes. And I think what we'll be looking for is for larger hubs, larger hospital systems to provide hub-like services, just because of the storage requirements that are involved in that. I'm going to skip over this slide in the interest of time. What we're asking hospitals to do now is to proactively enroll in our enrollment forms. That basically tells us that they've provided information, they've signed documents, and they're ready to receive vaccine when it becomes currently available. There's just over 300 sites currently enrolled, and about half of the tier 1 hospitals are enrolled. We're looking to increase those numbers in the next week or 2. And talk for a second about prioritization. Prioritization is a conversation we've been having for the past few months, focused mainly in the Vaccine Action Collaborative. There's been surveys to that effect. There's been initial discussions with the state health officer, with the governor as well. We're trying to plan for high demand, low demand scenarios as well. And we're also will begin vaccinating. The second vaccine is authorized, receives ACIP recommendations, and is available to us. We don't want to waste any time. And we're going to work hard to avoid vaccine loss in the process. As you saw earlier, once you take these vaccines out of their shipping containers and you dilute them and get them ready, you have 6 hours for one of the products before you lose that. You have to use it. So it's going to be challenging, I think, to maximize those doses. And our priority will be having no vaccine go to waste in that process. And I do want to end here before questions. I wanted just to show, I think it's important to give the team credit when credit's due. This was a slide from a federal briefing that we had with a number of other states a couple of days ago. And I'm just pointing out, you can see the large blue arrow. They ranked Louisiana amongst the 5 or 6 most prepared states right now to receive the administered vaccine. So it's a boost of confidence to our team. And I think they're doing tremendous work. They're supported by a number of people on this call. So I do thank you for that. But we have a good team working on this. I'll pause there, and Dr. Brown will be more than happy to answer any questions if there are any.
Yes, we'll open up for any questions for Dr. Cantor at this time. Also serving on this collaborative is our task force member, Dr. Keith Ferdinand, and Dr. Earl Benjamin Robinson. So they are representing the task force on this collaborative, and we thank them for their work as well. So we'll open it up for any questions at this time to Dr. Cantor.
I have a comment.
Yes, sir.
Yes, Dr. Ferdinand.
Yeah, I'm very pleased with your report, and I trust in your recommendation that we would receive and accept this vaccine. We need even more confirmation on the phase 3 safety trial, but from what you have stated, you seem to be very convinced that it's safe and effective. Is that correct?
Well, I'm convinced that we'll get the data. Essentially, I mean, the initial reports that we've received, both the Pfizer and the Moderna, out of the numbers that I saw recently or talked to Dr. Fauci about, 5 or 6 positive infections in 90 or 95 individuals was the initial top line number that I saw, which is very encouraging. We've not seen safety data yet, and that's not been published, but the assurances that we've gotten, again, both public assurances and a number of offline assurances, particularly from Tony Fauci, that the safety data will be made publicly available at the time of either FDA, EUA approval, authorization, or the ACIP recommendations, which we would not begin vaccinating before either of those two happened. Gives me a lot of confidence.
Thank you for the granularity of your answer. And I think this committee, with the entire group, would welcome your follow-up presentation to us when that happens, because we're going to be what's called trusted messengers. That's the term of art that SEAL is using. And the trusted messengers, when we say something, we need to mean it. Most of us have had very good careers, and we would not want to lose our good name behind something that's been then shown to be false. So you teased out a little bit more. It was less enthusiastic than when I heard the first time, but I'm pleased that at least you're looking at it closely.
Yes, sir. Thanks. I do. I think we're gonna need your help. So I appreciate the offer.
All right.
Can you comment on the work of the committee regarding dealing with the issue of mistrust, and in particular mistrust in Black and Hispanic communities, and also comment on strategies to ensure equity in the distribution of the vaccine to rural parts of the state and other communities that are often left out?
Yeah, thanks, Dr. Levy. It's a great question as well. Really, it's the biggest concern in my mind right now, is that we're not going to be effective at making vaccine practically available in the very communities that have been hit the hardest, have the most to lose every day this pandemic goes on. So I think that's the most important thing right now. You know, I think it starts with being able to show good data and data that is meaningful for each population, each community. I'm encouraged that Pfizer has done a much better job enrolling marginalized communities. I mean, 20% African American Latinx is a marked improvement from where they were a couple months prior. Not where they need to be, but much, much, much better. So I would hope to be able to take that type of data and get that type of granular data when it becomes available to show that the vaccine meets efficacy and safety expectations in different types of individuals, particularly where we're going to be pushing. I think as the previous gentleman mentioned, we're going to have to rely on trusted spokespersons and community members across the state to push that message forward. I think we're really starting from a challenging place where confidence in everything right now, because it's become so politicized and in the context of historical inequities and significant institutional racism in the health system in Louisiana. We have our work cut out for us.
So if I could just follow up, talk about the strategy of how you will go about convincing the trusted messengers to put their credibility on the line to endorse the vaccination.
I think it just starts with the data. And when the data is available, I think we need to convene, and I think we need to discuss, and I think we need to come to a reasonable agreement about what that data says. I don't think there's any expectation of pushing anything if we don't feel that the data supports it, not from us and not from anyone else. So I look forward to that conversation. I have confidence that the data will be made available, and then I think we look at it and we see where it directs us.
Let me also add, if you don't mind, Dr. Cantor, Dr. Levis, we're having those conversations. I shared in our last meeting the sentiments that Dr. Ferdinand shared in the last task force meeting regarding those issues. And we are continuing to have those conversations about being very, very measured in what we share with community, because I did express in those meetings that I have an integrity as a 19-year public health professional. I think everyone here does as well. And so we want to be very measured in our response. And we also want to make certain that we are sending the right message to the communities that we serve. And so we are paying very, very particular attention to what we communicate and how we communicate, because we want to get this right as best we can. And so, yeah, so we continue to have those conversations, and we are working those details out as best we can. And I invite anyone who wants to be a part of those conversations to please let me know, so that you can help us in creating those strategies, because it is hard. And so and it's something that Dr. Cantor talks about at length when we have conversations, and it's something that is top of mind. And we know that there are populations who have every right to feel the way that they feel regarding historic issues that have happened. And so it is a difficult conversation, but we have to be very, very intentional about mapping out strategies. And so anyone who is interested in helping us to create communications to move that process forward, please let me know. And so I invite you to those efforts.
Yeah, and I'll just add, thanks, Dr. Benjamin. Dr. Levis, I don't think I would feel comfortable pushing a message like that forward, nor would I feel comfortable asking you or anyone else on the call to do that in the absence of data to support that.
Dr. Cantor, secondarily to the trust issue is what the task force is really concerned about is the equitable distribution. Usually the folks that need it the most are the last to get it. And so it goes back to the issue of access. And so some communities, some hotspots that we have targeted that have high incidences of COVID do not have access to CVS or Walgreens in their local communities. So as you are strategizing, consider some interventions that will be able to provide, vaccinations to those communities, bringing that accessibility to the areas.
Yeah, I'd be remiss if I didn't mention that, this Dr. Wiltz, that community health centers are serving 470,000 people in the state, and we have 300 access points in 59 of the 64 parishes, a lot of them rural. One of the challenges we've had, the local hospital here cannot accommodate the storage requirements for the Pfizer product. So right off the bat, we've been in constant contact with the local hospital and Dr. Riggins in Region 3. We are, just this week, we did a drive to test. We received a grant from Centene to test for PCR testing for COVID, as well as serological testing and using robocalls. And we're doing some piloting that is really very promising. We had a great response in a rural community. So that is a concern of ours. But we do have a network, and we're doing some dry runs right now in preparation for that. And, you know, trust doesn't come overnight. You know, we've been around for 50 years as FQHCs, and I think we have a very high level of trust that's going to serve us well.
Thanks, Dr. Wells. You all have worked hard to build that. I know a lot of your peer clinics have as well. From a reimbursement standpoint, the vaccine itself will be free of charge to the state, free of charge to every entity here and the individual. There'll be a modest administration fee that would be covered by insurance, and any uninsured patient would have that fee covered from the feds directly. So there'll be decent incentivization for providers to give this out, I think.
We have a question in the chat box. Is there a way to leverage faith-based organizations to help with distribution? For example, health fairs.
I think there is. I think the first thing we would ask for faith-based organizations is to help with education and awareness. I think I would imagine hosting sessions, Q&A sessions, giving people an opportunity to talk to health leaders in their area. I think down the road, when we get to general public vaccination, which realistically we're talking about late spring, early summer, I think in terms of physical spaces to host vaccine events, absolutely. But I think we'll have some asks of our faith-based partners well ahead of that.
Great. We can take one more question.
Dr. Levis, in that same spirit, I think we should be informed by what's happening with testing right now. If faith-based institutions are involved in testing, if community organizations are involved in testing, places where we see people having a trust for testing may inform us about what people may have a trust for vaccination and those kind of things as well. I think what's happening is with things like testing, where you have faith-based institutions and others who typically are not involved on the healthcare provision side, now they're finding a link that makes sense. And so much of that is about trusted ground, and maybe we ought to be informed by what we're seeing from a testing perspective, what's working in our communities in this testing, from a testing perspective, and maybe that will inform about what we, given the fact, understand that sometimes a vaccination with reference to whichever one is chosen, there's certainly some cold chain issues and other things like that that you have to pay attention to. But notwithstanding that, I think we're finding some, during this pandemic, some more and more trusted ground in faith-based communities and in communities in general. I think we ought not to lose that lesson.
Yes, thank you for that. Good point. So thank you very much, Dr. Cantor. I know that we can count on you and the task force to come back to this group. We would certainly like to hear see the data once it's presented and play a role in helping to get the vaccine distributed throughout the state. So thank you for your time, and look forward to talking again.
Thanks, Dr. Levis, and thanks for the partnership and the support, everyone. Really appreciate it.
Thank you. Thank you, Dr. Cantor. We have to make one adjustment to the agenda because Secretary Robinson has to attend another meeting. And so we'll have her present next on an update of cost of care of COVID-19 and some initiatives.
Thank you, Dr. Brown, and thank you to the members for indulging me. I let Dr. Cantor go first, and he is going to the same meeting that I have to go to. So just in terms of follow-up from our last meeting, Dr. Benjamin Robinson is going to update everyone on the health equity dashboard, and that's part of the update that I'm going to give, but one is just in terms of the funding and the recommendations that were made. So the Subcommittee on Policy and Regulatory Affairs had some recommendations in their report. A couple of those recommendations focused on prioritizing increasing the economic security for those populations who had been disproportionately impacted by COVID-19 and are most economically disadvantaged in Louisiana, and also dedicating funding for communities that have been most impacted by COVID-19. So that begs the question, what are the economic impacts of COVID-19? And how do we start to address those? Earlier today, the Resilient Louisiana Commission released its report, which both the co-chairs, Dr. Brown and Dr. Levis, have been participating in those meetings with the RLC and including recommendations from the Health Equity Task Force, making sure that health infrastructure and health equity and health disparities were part of those recommendations. So the Commission's long-term recommendations include making strategic investments in public health infrastructure, as well as healthy food programs, rural hospital stabilization, and creating an Office of Social Equity. I think it's important that we continue the research on the economic impacts of COVID-19. So one of the recommendations and the follow-up is to research those economic impacts. I've had a conversation with the Louisiana Public Health Institute, which I'm not sure if Shalina Davis is on. There are a lot of people on the call, but we've had the initial conversation. The Louisiana Public Health Institute would do the work with the task force on really researching those economic impacts of COVID-19 on the communities, how the mitigation strategies that have been put in place have impacted those communities, including such things as school closures, business closures, stay-at-home orders, how they've affected employment, housing, small business ownership, finances, and the overall community stability. Taking that research and having it feed into the recommendations that are coming out of both this task force and the Resilient Louisiana Commission, so that when those decisions are made on how we address social equity, how we push forward with retraining programs, employment programs, education programs, expanding broadband and living wage initiatives, increased opportunities for women and minority-owned businesses, and addressing the social determinants of health, that we have the data to support it, and that data is driven by this task force and the research that's done. We would propose that the members of that subcommittee work with LPHI in developing the data sets that would be worked on. And we also use the information from the dashboard that Dr. Benjamin Robinson will provide additional information on when he does his presentation, and that we continue our work using the funding that is available, which we have about $310,000 of the grant dollars left. And some of that will be spent on some of the work that Dr. Robinson is going to propose, and that we use additional funding from that to go forward with this. That is the recommendation, and I will answer any questions that anyone may have.
Any questions?
Yes, Dr. Robinson. This is Derek from the Communications and Messaging Committee, and we are also hoping that there'll be some funding available for us to continue pushing those messages.
Of course, always competing funding.
I understand. I understand.
Always competing.
All right. Well, thank you, Secretary Robinson. We want to make sure she gets to her meeting. Is there any other questions for Secretary Robinson?
And I do see at least one comment in the chat to make sure we consider the role of rehabilitation to minimize economic loss. So
yes.
And I think those will be captured, the comments in the chat, right, Dr. Williams?
Yes.
Okay.
And Dr. Fowler asked about a toolkit for faith-based organizations as it relates to vaccine campaigns. So that's something that we certainly can consider.
Okay.
And so before we let Dr. Secretary Robinson leave, are there any other questions for her? Okay. Thank you so much for joining us today, Secretary Robinson, and for your update.
All right. Thank you all.
Okay. Dr. Levice.
Yes, so a theme that's come out several times in this meeting is the importance of communications and community engagement around this pandemic. You know, this committee has its communications arm as well. But the National Institutes of Health recently has funded a project that is a collaborative of universities throughout the state of Louisiana to work on communications. And Dr. Tonette Crosser-Woods is here today to talk about that initiative where several others on this committee is also involved. So Tonette Crosser-Woods, Dr. Crosser-Woods is a professor of medicine and epidemiology and associate provost for health sciences at Tulane University and heading up the initiative. And I'll let her describe it to you. Thank you.
Thank you so much, Dr. Levice. I'll go ahead and share my screen. Hopefully. Can everyone see?
Yes.
Okay, wonderful. Well, again, thank you, Dr. Levice and Dr. Brown, for the opportunity to talk with this distinguished group. I was hearing all the introductions and certainly was amazed. I also want to gratefully acknowledge my co-PI, Dr. Daniel Sarpong, who's a member of this task force, but we are working side by side on the LaCille project. And of course, I want to thank so many of you who are on the phone, who are on the call today, who are also part of the LaCille initiative, and for all your efforts to date in helping us prepare the application, but also in moving things forward. So thank you very much for this opportunity. So over the next few minutes, I want to give you just a brief overview of the SEAL program that the NIH launched literally just 2 months ago. And also want to give you the specifics of what the Louisiana SEAL, the Community Engagement Alliance Against COVID-19 Disparities, means with respect to the partners we have here already engaged in Louisiana, our objectives that we proposed, our timeline, and what we're doing to prepare the foundation for the Halt COVID education program for Louisiana to help us address this abominable pandemic that's adversely affecting our communities. We'll talk a little bit about, some of the progress that we've had to date and the next steps throughout this brief presentation. So the LaCille, as Dr. Levice already mentioned, it's an academic community partnership. The co-PIs are myself and Dr. Sarpong, bringing together both Tulane University and Xavier University to make a difference in Louisiana. We are one of 11 of the state SEAL programs that were funded. You can see Louisiana in bright red there. And we are also working with the co-VPN organization, and our co-VPN code is listed here as well. But this partnership and this lead here only works and will only matter to the people of Louisiana is how we involve our community partners. So we have, in alphabetical order, involved already community pharmacies. We have 8 federally qualified health centers, most of them, actually all of them, that we have been working with actively over recent years to address disparities and issues around chronic disease in this population. We've also engaged faith-based organizations, the Louisiana Department of Health and their health promotion ambassadors, the Louisiana Primary Care Association, the Louisiana Public Health Institute, LSU, the Skin You're In multimedia campaign, Tulane University, the United Home and Nation, the Urban League of Louisiana, and of course, Xavier University. We have also leveraged other resources that are here in Louisiana through the LCATS program, the Louisiana Clinical and Translational Science Institute, Tulane's Translational Science Institute, and efforts that are available through the Gulf South through the UAB CCTS. To date in Louisiana, we have 114 individuals in just 2 months that are working on the Louisiana SEAL, and we're still counting. It's an amazing collaborative between these groups. Many of you are represented here on the call today, know how important your role is as we begin to delve into what we need to address this pandemic in Louisiana. So Dr. Levies also mentioned that it's NIH who is funding this, primarily from NHLBI and the National Minority Health Institute and focus on disparities. This is the first time I have ever seen NIH actually give money so rapidly to find out what communities' concerns are by doing a rapid needs assessment, as well as coupling this with using the information obtained from the community, the people with the boots on the ground, to develop an educational program that can meet the people where they are. And this is just critically important. And I'm very excited that NIH had the foresight to do this. They set out a mission statement around this initiative for the Community Engaged Alliance to provide trustworthy information through active community engagement with investment in and outreach to underserved communities to build long-lasting partnerships and improve diversity, inclusion, and our scientific response to the COVID-19 pandemic. We all know, and all of us on this call know, how important our vulnerable communities are to the fabric of who we are here in Louisiana and beyond. And so this is critically important that we make sure that they are in the line at the table with access to what we're doing in the scientific response. The vision for the SEAL from NIH's perspective is to be the most trusted partner in community engagement efforts in addressing the scientific response to COVID-19 pandemic and the related disparities. So they set forth 2 goals when they made this announcement, which, by the way, they announced this in August. We were given 10 days to respond. Again, many thanks to many people on this call for being so rapid in that response. And we actually got the notice of award within 10 days after submission. But the goal, because of the emphasis on the urgent community engaged research and outreach, focused on COVID-19 awareness and education. And this was primarily to address the information about the widespread misinformation about COVID-19 and to promote an evidence-based response to the disease. It's already been mentioned on the call today, the importance that we must have the evidence to develop an education program that we can all stand by and can deliver with confidence. And so that's part of this process. The second SEAL goal is to promote and facilitate inclusion of diverse racial and ethnic populations in the COVID-19 clinical trials, whether they be prevention, vaccine, or therapeutics, that are reflective of the populations that are being disproportionately affected by the pandemic. But it will go beyond just the trials. It is also relates to being involved in including a diverse population in all of the things that we're going to do in response to COVID-19. So critically important that we don't leave any of our populations behind or last in line in this process. As part of this initiative, just on the national level, so that you know, there are 4 major working groups that are providing oversight of the activities that are happening in these 11 states that were most adversely affected by COVID-19. We have in blue at the top with our representatives from Louisiana that are participating, and you can see from Tulane, from Xavier, from our FQHCs, from LSU, and from our community physicians, those that are represented here. We have an overall steering committee that it's overseen by myself and Dr. Gary Wiltz from Test Action Clinic. We have a communications working group that's well represented in Louisiana by Drs. Connie Arnold and Sharon Roberts that look at the repository of materials, identifying opportunities for the common messages, as well as making sure that we are addressing health literacy to make sure we can meet people where they are and give them the information they need. A very important committee right now is the working group that's focused on the needs assessment, led by Drs. Kat Thial and Aaron Peacock from Louisiana. Again, looking at the survey tools, developing the opportunities for the common data analysis and dissemination, and working regularly, not only in Louisiana, but networking with our other colleagues in the Gulf South, and including Mississippi, as well as Alabama, because we have some unique aspects of being in the Gulf South for our vulnerable populations. And we feel that by sharing best practices and best promises, as I hear, that this will be the best for Louisiana as we learn from them. And then, of course, inclusive participation is represented very well by Dr. Sarpong and Keith Ferdinand from our Louisiana group. And they are actively looking at the resources that are going to go to members with respect to the language, what sort of NIH clinical resources and trials can be reviewed, what's the information on Operation Warp Speed, what are the vaccine trials that may be near you, and of course, key to this is discussing the best promises for inclusive participation. And these groups are just providing a wonderful representation of Louisiana. That's what I'm hearing from the National SEAL, but most importantly, bringing back key information to us. The other thing that's happening on the national level, and we would be happy to make any of this available to anyone, the SEAL initiative is about Louisiana. It's not about Tulane. It's not about Xavier. It's not about even any one of our partners. It's about the people in Louisiana. And so they have made all of the resources, the materials, education materials, slide decks, whatever, readily available to anyone so that we can expedite the review of information and provide it to our communities. So we have got an outstanding communications advisory committee working through the Louisiana SEAL, identifying what we can use as is on our website, what we need to adapt for Louisiana using our local talent and the local leaders as part of that. As the evidence emerges, giving us confirmation that the vaccines are safe and effective and in all of our populations, we want to be poised and ready to move this to the next level. So the Louisiana SEAL, we proposed 4 objectives when we submitted our application. The first one in direct response for a rapid assessment at the community level to look at awareness, understanding, and misinformation around COVID-19. We chose to include not the opinions and the perceptions of our patients, our providers, our community leaders, faith-based leaders, and healthcare providers and administrators. Very important, we thought, to get that perspective on COVID, social determinants, as well as other barriers to COVID-19 prevention. Our second objective is to use the data that we're collecting based on this rapid assessment to develop and to design a Louisiana SEAL HALT COVID educational program that's going to meet the needs of Louisiana. Our focus initially, because of the data that you all are all very well aware of, is on the Black population, but we are also engaging our Vietnamese, our Hispanic, and our tribal nations in our efforts in providing the information to them as well. The third objective is to rapidly implement and evaluate this program. And ultimately, for our fourth objective, we want to create a sustainable infrastructure in Louisiana that supports our community engaged research using these partners that we've already established to help us get out information about COVID-19 and build our research capacity so that we can build the evidence to fight this pandemic and to fight the misperceptions. So our population of focus, they gave us limited funds at the NIH, but we're very pleased with the funds we got. But we focused on the hottest spot areas in Louisiana, which are Orleans, Jefferson, and East Baton Rouge parishes. Knowing Louisiana, as we all do, we also knew that we had to expand to the rural parishes that are nearby our hotspot areas. So we did that as well. Given the data, as you know, with Blacks being 32% of our population, and at the time that we submitted the application, they were 40% of the cases and 48.7% of the deaths, we knew that this was an important area for us to target in the hotspots. But we are also building the capacity in our Hispanic, tribal nation, Vietnamese, as well as expanded rural Louisianians. The FQHC clinics, this kind of shows you how we're doing this. We've gotten 23 clinics from the 8 FQHCs that are participating already. We've signed the subcontracts. We've done the training to launch the needs assessment, and already that is being launched in some of the clinics this week. And we anticipate that by December 1st, all will be moving forward in a positive way with our needs assessment. Our community concerns about COVID, our CCC survey, is how we're going about the deeper dive, one aspect of the deeper dive, to get information back from at least 1,500 community members. You can see here that we're going to do this in a number of ways. Our patient populations on the left-hand side at the FQHCs, We're asking these 23 clinics to collect at least 50 surveys each, and they can do this either by telephone or in person. We've also working very closely with Xavier and the pharmacy students there. They've identified 3 community pharmacies, which will help us gather 200 surveys, again, using telephone as well as in-person engagement. Also with Xavier's connections with the faith-based organizations, both through Baptist ministries as well as the Archdiocese, already working with the faith-based leaders to identify how we can get into their communities to get their feedback on what their concerns are. Again, using both telephone and in-person efforts. And then of course, we're also going to look at the targeted neighborhoods in the greater New Orleans area using a group from Cap Theol, and again, telephone and in-person visits. We're not only compensating the community partners that are helping us with this initiative. This was very important to the NIH that money went to these groups who are helping us with this research, but also that the participants get gift cards for their time that they spend in giving us the information. The core survey, because people ask about this, includes all 11 SEALs will be collecting the first half of it, which is the core survey that includes 4 items on prevention around COVID-19, 6 items about clinical trials, and 17 items on the social determinants of health and demographics. We're adding just a couple of more questions. We wanted to add more, but time won't permit it, regarding additional social determinants of health and questions specific around vaccine hesitancy. We've designed it to where it doesn't take more than 30 minutes total, including the administrative aspects of it, but the survey questions taking about 20 minutes. Very grateful to our team from LSU Shreveport for the work they do in health literacy and helping us make sure that we're addressing the questions right. Led by Dr. Sarpong and his team at Xavier will be the focus groups and the key informant interviews. The focus group discussions are targeting 150 community members to brainstorm about the community assets, identify promising strategies, and facilitate participation in the initiatives around COVID-19 prevention and treatment. Also, key informant interviews with about 40 community leaders, including healthcare providers, faith-based organizations, and healthcare organizations, will be done and are already in process. And he can answer questions about that. The domains that are being captured in this group are sources of information, where people get their information, concerns about discrimination in COVID-19, trust in COVID-19, spirituality in COVID-19, and then information around vaccines and treatment. And we really believe the survey is going to provide us a great deal of information, but the rich information we're going to get from these discussions are really going to provide a springboard into developing the right COVID education program for our communities. We are also looking at social media analysis. I'm incredibly impressed with Dr. Sharon Roberts at Xavier, who has educated me on social media, who I don't spend much time on it, but how this was initially proposed by Dr. Theol and Dr. Roberts, that this would be used not just as a mechanism of just getting data, but it's also an evaluation impact marker. So this is very important because it also gives us a source of information on trends and social norms about COVID-19. It expands beyond Twitter. So we're looking at Twitter, Instagram, and Facebook. The information that we're capturing is the ways that people talk about vaccines, the way they talk about testing, treatment, the CDC approved behavior, other preventive behaviors, as well as social determinants and health disparities. So the terms that we've already identified are going to help us understand some of the concerns and again, give us a better opportunity to develop a more effective program. And here you can see the process where we get the tweets, the posts and comments, they're pre-processed, they go into a rule-based categorization, topic modeling, and ultimately help us define the health behavior constructs. So our LaCille timeline is proposed here. We had to move our community assessment out through December because of some delays at the national level on defining the core items that would be captured across all 11 groups. But because of tremendous effort on behalf of our entire team and several of the groups at Tulane who are leading the core survey, we believe that we're going to meet our goal to complete the survey by the end of December. Already, the development pilot testing of the whole COVID materials are being reviewed by our Scientific Communications Advisory Committee, all serving as that initial platform for developing the phase 1 and ultimately the phase 2 Halt COVID program. As I mentioned, we had 12 months total for this project. We're already 2 months down, 10 months to go. We have an aggressive timeline, but my goodness, we're in a pandemic and it's an urgent call for all of us to step up to the plate. So you can see here that our plan is to be able to begin to roll out the phase 1 of the Halt COVID program, provided we have accurate data in January, with phase 2 rolling out beginning in February and extending out through the spring and into the summer. And then we'll be doing an assessment of the sustainability, over time as well. Hopefully the expanded and extended dissemination to broader communities will be happening in late spring and through the summer, so that we can provide feedback to our community, to Louisiana, and to NIH on what works, what doesn't work, and where we need to improve. So our outcomes for the LaSalle, and each and every one of you will be a part of this process if we're successful, or can share in the success, is really to create the sustainable infrastructure in Louisiana that supports timely dissemination of accurate COVID-19 information and resources. We want people to have the information so that they can use it for their decision making. Not trying to make anyone do anything, but we don't want people to not do right behaviors, not get a vaccine because they didn't know, they didn't have access to the right information, or they didn't have access to a site. We are working to build the research capacity in our vulnerable communities by working with these trusted partners that we've already established relationships with, and we thank you for that, and ultimately provide the evidence for a community responsive Halt COVID education program. We want to increase inclusion of our vulnerable populations in COVID-19 trials and health programs as it's appropriate for them to do so. To not be included, we all know what that means. We won't know if it's safe and effective in all groups that can be affected by this pandemic. And we know how critically important it is that we have that information, because each and every one of our Louisianians is important to our present, they're important to our future, and they're worth the investment of time and energy to make sure we have what we need for next steps. So I thank you for the time, and both myself and Dr. Sarpong are available to answer any questions about LaSalle.
Great, thank you. Thank you very much. Do we have any questions? Dr. Sarpong, do you have anything you'd like to add?
No, Dr. Crystal-Wood did an excellent, outstanding job, so I think nothing to add.
This is Dr. Ferdinand. I'd like to say something.
Please do.
The SEAL program coming out of NIH does have a certain amount of validity. I know some of the principals at NIH who push to have this funded, and I think they're sincere in their efforts. We need to just make sure that we integrate whatever messages we have with the objective data when we get it.
Absolutely, Dr. Ferdinand, and that's one of the reasons that you are participating with us on LaSalle and on that important committee. We're looking forward to having your engagement and your sage advice.
We have a comment in the chat from Dr. Christian Engel, who says not to forget about the YMCA and other nonprofits who are already receiving funding from NIH, health insurance, hospital partners, and private funders.
Excellent suggestion. Thank you very much.
Let me just make a comment, this is Dr. Wiltz. I think that is a great presentation. I've seen it a couple of times now. I think it's
sorry about that.
But it can lay the foundation moving forward, because the insightfulness and the detail of that survey, as you know, I think it started with like 1,000 potential questions, and it's been honing down, but it's invaluable as we talk about trust on the front end, to ask the people that, we're trying to affect, how they define it and how we can respond to it. I think is going to be invaluable, not only in this crisis, but as we get out of this crisis, moving forward and all the chronic diseases and all the things that we know we have to deal with to, make Louisiana a healthier state. So great work.
Thank you, Dr. Wiltz, because you are certainly providing an important voice at all levels with the LaSille. So thank you.
Okay, thank you so very much, Dr. Crossell-Wood, for your presentation today. And we look forward to, hearing from you again with the results as you move forward. Okay, next on the agenda is an update from LDH and the Health Equity Dashboard, and that is Dr. Earl Benjamin Robinson, who represents LDH, and co-chairs on the Health Equity Dashboard committee members are Dr. Demetrius Porsche and Ms. Judy Reese-Morse. Dr. Benjamin.
Good afternoon. I'm gonna have a co-presenter who comes in, Catherine Kane, who will be helping toward the end of my session. Hopefully this will take no more than 15 minutes. The latter part may take some time, but we can reschedule because I think it's important that the database that we review in particular be reviewed probably more in-depthly with Dr. Levis and Dr. Brown and the others from my work group at some point at length. So this will just be a brief review of that. And so two things will be reviewed from this presentation today. I have two updates from LDH. FYI, moving forward as the task force meets, I've gotten permission from Dr. Levis and Dr. Brown to share updates with you guys from LDH. And so from time to time, LDH will be providing updates to you guys either via myself or someone else from LDH. Today it was Dr. Cantor replacing Dr. Welch. And some of those updates will be related to recommendations that you guys made, and sometimes it will just be things related to what's going on inside LDH. We're doing this because we want to make certain that you guys are aware of what it is that LDH is doing in relationship to meeting the needs of the citizens of the state. And so two things that I want to share with you guys that have a relationship with some of the COVID work that we do is that one update is that the K through 12 superintendent reporting, there is an update, enrollment in early warning systems. Public health officials can monitor and mitigate the potential for new cases or breakout. This centralized system location prepares schools to respond appropriately to an outbreak, collect a school-wide case information, and proceed with contact information. And so and I'll share this presentation with you guys via email. I'll send it to Tracy so that she can share it with you guys. But information related to this can be found at this link. And again, this is just an update relating to how individuals can get information on COVID-19 reporting related to K through 12 school settings. The second update is related to antigen testing. We have put this information on the database, the COVID database. Don't confuse this database with our health equity database. This is a different database, but we've made a few updates on the COVID-19 database. The antigen testing the use of the antigen test has increased substantially over the past few weeks. LDH indicates case determined through a positive antigen test as probable. Individuals can be counted once as confirmed or as probable case, not both. Deaths with the positive antigen tests are classified as probable. Test counts now include both PCR, molecular, and antigen tests. Antigen tests are included in all relevant graphs and charts in the dashboard except percent positivity. Again, I will be sharing this presentation with you guys, so you'll have this information shortly. Specific to that additional date is percent positivity change. LDH will display COVID-19 cases as a cumulative weekly percent positivity instead of daily percent. The daily bars, weekly bars, no change in CDC recommended calculation. Cumulatively weekly percent positivity is more informative than the daily percent approach. includes more data within a weekly time frame, and prevents data skewing due to differences in daily testing procedures and protocols. And so those were two updates that we just wanted to make certain that you guys were aware of in relationship to COVID-19. School reporting and updates to the COVID-19 dashboard. And so I am a member of the Taskforce dashboard, Health Equity Dashboard, and we recommended that there be a health equity dashboard created. And while we were in the process of developing these recommendations, the Louisiana Department of Health was already inside the Office of Public Health in the Bureau of Planning and Performance. They were in the process of developing a dashboard. They were developing a dashboard to meet the needs of the state health assessment and state health improvement plan. And so at the end of our recommendation process, before even we started meeting with our work group, I was already having conversations with that bureau director, Catherine Kane, and so we were having discussions. So when we had finalized our recommendations, we decided to have a crosswalk to see if we could merge efforts. And so I was able to get the co-chairs of this work group, Dr. Porge and Judy, to come together and meet with Ms. Kane, and we found that the needs, the recommendations that we had outlined were met via this dashboard. And so the chairs just recommended 2 additional things that needed to be added to the Office of Public Health, our LDH's dashboard. And so we'll be utilizing the Office of Public Health, LDH's dashboard to meet the needs of the recommendations that we have outlined. So we're excited to show you guys the dashboard. It is in its initial stages. Again, it is not finalized yet, and we will be adding the recommendations of our chairs to it, which is adding some additional narratives and stories to it that help to build people's capacity to use it, and also a bit more activities around getting a consultant to do a bit more work with it. And at this time, Catherine, are you here? Are you on?
Yeah. Yes,
hey.
hello.
Hey. So at this time, and this is Ms. Kane, did you want to go ahead and I can stop sharing, and we're going to just do a brief run through of the website. Oh, well, I guess I can. Okay. We're going to just go into the site so you guys can see it visually.
Yeah, so thank you, Dr. Benjamin Robinson. Yes, so this is our site. It's not publicly available yet, but so we're making some adjustments before we can launch it publicly. And I'll just say a couple of points to just kind of reiterate what Dr. Benjamin Robinson said. One, the purpose of this is to meet our requirements for state health assessment. It doesn't have to be branded that way, but that's why it's called state health assessment. It's not an action plan site per se, but it's a data site. So it's meant to just paint the picture, not to take precedence over people's lived experience. And hopefully, when this can be sort of reinforced with more stories and a narrative that can be, amplified there. But this is not really meant to be an action plan. That can be a separate product if we want to go through a process of prioritizing and developing strategies and developing performance metrics and action planning. That can be done. But for now, this is a painting a picture of health and health equity or inequity in Louisiana. That being said, we can't include every data point, but we have we've had to be selective because the site can only handle so much data and then it starts to get overwhelming. And so my team selected it, and I'll also just shout out to Dr. Flint Mitchell, who's on this call, who is on the team that developed this with my sidewalk. So we can't add more visualizations than are already here, but we can swap things out when we get feedback from folks. And that's the beauty of this whole thing is a website, and this is just the initial build out. So it can evolve. And just another note that it's currently written at the 9th grade reading level, so it's meant to be accessible. It's built with an equity lens, using a Prevention Institute framework that shows that health is a journey. And so you have structural determinants, which here are called foundations of community health, that lead to exposures and behaviors that lead to medical conditions that ultimately is health inequities. And so the site is structured that way. As you can see, you've got this introductory page. I'm gonna skip around a little bit. So you've got demographics here. And also you've got statewide demographics, but also every page you can, if you want to see data according to the specific OPH region, you can do that. But the general page, the main site for each of the links on the left-hand side is going to give you a statewide view. And so again, this just kind of goes over briefly, demographics is pretty standard, demographic breakdown, so you can kind of get a feel for that. Going to the Foundations of Community Health page. So this is really where we're trying to tell the story of structural determinants, social determinants of health, barriers to health, however you want to call it. And so there's a lot in here: early education, incarceration, income opportunities, including ALICE households. And there's a lot of visualizations. It goes on to housing. And so there's a lot of visualizations in here that can really be unpacked. And where possible, the data is really shown broken down by different demographics, whether it be race or whether it be urban, rural. Because when My Sidewalk was doing an analysis to really, before they built this dashboard, they really looked to see, okay, where are the inequities? And so racial inequities was one of the main themes, and also rural versus urban inequities was another main theme. So that's why you see a lot presented that way. But and so there's drop downs that you can really, you can really kind of dive in to these data and get a sense for the inequities that occur. So not to take up too much time, I'm going to jump down to medical conditions. Well, actually, hold on, sorry. I'll go to behaviors and exposures to kind of go in order. So again, this is structured that, these are a lot further along in the trajectory. You have your behaviors and exposures. You have your exposures in the physical environment. You have respiratory hazards, exposures in the community, violent crime rate. And for each one, it's, you can click here to see, for example, smoking by race and ethnicity, and you can kind of see the differences in smoking rates and physical inactivity by race. And so wherever possible, things are kind of broken down that way. I'm kind of going kind of fast, but there's really a lot to explore, and the medical conditions we have. You can see the health outcomes rank. This is pulled from the county health rankings. So that's here. You can kind of see that as a snapshot, where the darker is the lower parishes that rank lower in the health outcomes. And again, there's all these drop down boxes where you can really see, you can really kind of dive into the data. If you want to look at, physically unhealthy days by, different demographics, it's here. For example, physically unhealthy days by race, ethnicity, or by, education level. I mean, and some of these is pretty telling when you can see, the impact of something like education on how healthy someone is. It really kind of tells an income level, for that matter. It really tells the story. So there's a lot here. Look forward to making it available for your review. And with that, Noopsius, I'll hand it back to you.
So some of you may be asking, or maybe thinking, this is a lot. And yes, it is a lot. But this is the beginning. And so to community members, what we will be doing is, earlier I said, the chair said, the next two steps would be to create narratives and stories to help communities know what to do with this. What are the action steps? What are the next steps that we can do with this data? And so we will be working with a consultant to create. And did we already have that tab open, Catherine, the one you said?
Yeah, so we have a tab here called Find Your Role in Building Health. And right now that's not actually populated. my team is building out some draft, proposing some content there. And also this is kind of, there's a lot of potential. So this is
Right.
one page where we could really build that out.
So yeah, so this will likely be where we start to map out what to do with this. How should I take what I find out about my community on this page? What are my next steps? And so what we will be doing with the consultant is mapping out narratives, stories, and strategies to help build community members' ability to utilize this page. And so, because what we don't want this to be is just a place where there's just data and people don't know how to use it. And so the next steps will be to work with a consultant to help us map this out, along with possibly an urban league to do educational opportunities around the state to help build people's understanding that this resource is here, so that people are aware that this resource is here, so that they will utilize it. And so this is the beginning stages of it. We hope to release it relatively soon. This is a living thing. And so we don't want to just be sitting on it until it's perfect, but we want to as we get more information, as we get more feedback, we will be updating it and making it better and better and better. But we didn't want to waste an opportunity to work collaboratively with what was already happening inside the Office of Public Health. And so I thought it was a great opportunity. Many of the data points that the work group had outlined were already here. And so it's a great product. I think it's a good product, and we look forward to continuing with the collaboration and making this what it needs to be to meet the needs of the citizens of the state. And so we're open to questions, feedback.
Yeah, I had.
Thank you so much. Go ahead.
I'm sorry. Yeah, but yeah, it's great work, and I've been a student of the Shaw and Shawship process for a number of years. And you can't manage what you can't measure. And I think most of us have been citing the United Healthcare Foundation's 25-year ranking of Louisiana, followed by the Robert Wood Johnson Foundation county rankings, where they actually tell you why you are so bad and give you a roadmap, as you all know, to improve the metrics that can lower your score over time. The most recent one, my reading for this weekend, will be this one, the Measures of America series with the Portrait of Louisiana with the Human Development Index, which I found quite interesting. But at the end of the day, and I've said this, I guess, having done this 40 years, no one can help save us from us. It's those local community. It's going to have to be community driven. I think Louisiana has been the most studied state in the world. You got, the rankings from United Health Foundation, Robert Wood Johnson, Shawship. Now this is the Conrad Hilton Foundation and J.P. Morgan Chase, and so I think the metrics or the problems are out there, and this committee obviously is going to play an important role moving forward. But at the end of the day, as I've tried to, I have a quote behind me that says, "We're made wise not by the recollection of our past, but the responsibility of our future." I think it's important that whatever plan comes up, it's a living, breathing document that can outlive all of us. And the only way that's going to happen is the people in those communities, the faith-based people, the people that are born, live, work, and die in those communities, take ownership to continue it after this governor is gone, after all of us move on. It's the people in those communities that are going to drive this and make it sustainable. So I applaud though. It's a rich resource, and maybe I'm a nerd. I'm looking forward to reading it and comparing. That's always interesting to me though, the data that you collect, how the resources that the Robert Wood Johnson Foundation, how do they collect what they collect? How do we collect what we collect? And I'm curious to see how the Hilton Foundation and Chase, what data sources they use to collect the data they did, but great work, and I'm looking forward to reading it, and you all to be applauded. Just really great work.
Thank you, Dr. Wilk. One thing I want to add to this, the co-chairs, not only did they say, to work with the consultant, the other thing is the the work group recommended that the individuals on our work group continue to be a body that helps to inform the data and strategies that will annually be updated on this website, so that they don't want this just to be a one-time thing. Those, Dr. Kennedy, Porsche, Judy, there's someone else on Dr. Faust, all of those individuals, they want them to remain a part of the process, so that they are annually, ongoingly looking at the data, saying, okay, it's time to update, looking at the strategy, saying, oh, it's time to update, so that it's just not, oh, we did this 10 years ago. What happened? So yes.
Are there any other questions for Dr. Robinson? Any of your committee members want to add anything, Dr. Robinson? This is great, great work. It's a very comprehensive. The work of the LDH aligns with the work of the Taskforce Health Equity Dashboard Committee. You have produced, I just can't wait to see the end product. And I know it's living and it's evolving, but you've done some wonderful work here. And this was one of the key points that the governor asked of us to do, and that was to develop a health equity dashboard.
Dr. Benjamin Robinson, I'd like to chime in and to give again a shout out to you and the Katie Kane as well. I'd just like to point out to everyone that this dashboard really, as Katie mentioned, has a health equity focus. And, in the wake of George Floyd's death, in light of the health disparities that were highlighted through the COVID pandemic, we wanted to make sure that we created a unique product here. And so I haven't looked at every dashboard in the country, obviously, but I will tell you that this state health dashboard for the state health assessment is probably unique. The consultants that we worked with to create it, I think that they were excited about this spin. Although they've worked with other organizations to create dashboards with a health equity focus, they said that none had been created this way. So I think this dashboard is unique. It helps to try to take the emphasis off of the individual for their health outcomes. It really highlights, as Katie mentioned, these community or these foundations of community health, not only behaviors, but also exposures that lead to certain medical conditions. So you'll see in the narrative here, as we clean it up, as we complete it, that it really tells a unique story that does highlight that health equity lens and helps to take some of that focus off of the individual for their health outcomes. So I think you'll find once this is complete, that this product is obviously unique, but really be helpful as we work forward to improve the state of Louisiana's health. So thank you,
Dr. Mitchell.
Yes.
Thank you, Dr. Mitchell. So that's all we have. I mean, I just want to thank everyone on our work group, and in particular, Ms. Kane and Dr. Mitchell and Dr. Kennedy, Dr. Faust, Judy Morris, and Dr. Porsche for helping to bring this to fruition. And we look forward to making this even better. It is a living document. Katie and I would like to have this go live in December. Again, remember, we're going to be making it better and better every day. And so we just don't want to sit on it until it's perfect. And so we want to get it out there, but please note that we will have a robust campaign behind this to help build communities' ability and capacity to utilize it. And so it just won't be my office, and Katie's bureau will have a responsibility to make certain that community is aware of it and utilizing it. And so we will be putting resources and time and energy behind it.
Thank
Katie,
you.
is there
Thank
anything
you
you
so
want to
much.
add before we?
No,
Okay.
you said it great, Dr. Benjamin. Thank you.
All right. All right, Dr. Brown, I have to go to another meeting.
All right, thank you. Great work. We appreciate all that you were doing, Dr. Benjamin. Thank you so very much.
Bye-bye.
Okay, at this time, we'll have an update from our Communications and Messaging Subcommittee, Dr. Derek Riveras.
Good afternoon, everybody, and I'll jump right into our PowerPoint presentation. we've been steadily meeting as a subcommittee. The Communication and Messaging Subcommittee is made up of Lenore Carroll, Dr. Kesey Ferdinand, whom you've heard from before, Dr. Corey Hebert, Representative Moreno, Councilwoman Moreno has a Representative Sadie Finkel, who's been faithfully attending meetings. Myself as the chair, Janine Tate has been invaluable as a subcommittee member and now as a staff assistant to us, and the ex-official members, Dr. Brown and Dr. Levis. We reported to you in September about our billboards and some of the other messaging. And so here's some updates on where we have gone in the last 2 months and some of the things that we're working on going forward. We are currently working on a YouTube channel that will house all of our task force videos, and we'll share a couple of those with you as we wrap up this presentation. We also shared some last time. We're busy, we'll be busy refreshing the website. Our website has been pretty stagnant and we need to update it. As I listened to the earlier presentation, quite a bit of what we share, they have, and so we will probably look to link up those websites if that's possible. And of course, we're going to be getting our ad materials translated for Spanish and Vietnamese speaking audiences. Right now, they're solely in English. We have been buying ad time on the air TV specifically. You can see some of the channels there on your left, from BET to CNN, OWN, TLC, Lifetime, which is my wife's favorite. All of you guys can watch those Christmas shows over and over and over and over. My pain. Our total figures are about 17K for our Baton Rouge area broadcast. We're doing the same in several other areas in the state. So if you look at what we shared again last time, where our billboards had just gone up in September, there's a sample of one there to your right. We have billboards in 6 different locations: Alexandria, Baton Rouge, Houma, Lafayette, New Orleans, and the Shreveport-Bossier City area. Cable TV in several of those markets as well. And social media, of course, it goes around the globe, but we're focused some ad buys in several other areas listed below, in those locations listed below. You'll be interested to know that our posts have reached in a week's time 21,849 people on Facebook, which is really a pretty good number for a site like ours, and Instagram with over 9,400 accounts that have been reached in a 3-week period. That's all in the month of November. During the election, leading up to the election, we had a combined message. So we wanted people who were, many folks were concerned about the safety of voting, given the COVID virus. And so we had an ad campaign on social media and on television: make a plan to vote and stay safe. Here's a clip from one of our posts.
I just voted. Why? Because my ancestors risked their lives for me to be able to vote. But I don't have to. I wear this mask. I stay my distance. So together, we can move mountains. Go vote.
And we'd like to thank a committee member, that was Corey Hebert at the end there, and Dr. Griggs for Dr. Griggs' company actually helped produce so many of these videos for us, and we're very grateful for that. In case you had forgotten, prior to the election, there was a great deal of concern. And if you saw the lines for early voting, and then of course what happened on election day, quite a few folks got the message, and we were part of that messaging that it was indeed safe to vote. While I have the microphone, there is a December 5th election, so don't forget, we've got more to do, folks. We're working also with flu shot messaging. And so we work with the CDC and their Mask Up, Lather Up, and Sleeve Up campaign, encouraging people to get the flu shot. We also have a video clip that I'll share with you on that.
I'm Dr. Kesey Ferdinand. As the fall weather comes, remember, influenza will come back. Influenza, or the flu, is not just a bad cold. It can cause death and disability. So check with your physician, nurse practitioner, pharmacist, or other healthcare provider as to what flu shot is best for you.
Thank you, Dr. Key. And so we will be doing a few other messages around that as well, trying to encourage people to get the flu shot. And knowing that the combination of flu infection and COVID will be just more than what we can sustain. So we're encouraging people to celebrate the holiday safely. We're asking folks we're asking people to, if they can, to refrain this year, at this point in time, we're saying this year, to stop the gatherings that we always do here in South Louisiana and certainly in North Louisiana, Texas, Arkansas, anywhere down in the South. We like to gather for Thanksgiving. And I know people do it around the country, but I think Louisianans do it a little bit more, and we probably go a little harder at it. So what we're saying is stay at home. Have your dinner with those folks who live in your house as best as you can. There's no need to go over the river nor through the woods. Just stay home. One of our spots we're currently working on will be a spot with an empty chair this year for Thanksgiving, with the notion that we'd rather have the chair empty this year than have it empty every year. So we're encouraging people to again have a Thanksgiving dinner that is members of your household, immediate household, or people who live with you only, and trying to discourage folks from going and doing what we normally do. That's going all over and visiting in other homes. The CDC also has put out some guidelines. Again, it's the masking, the 6 feet, and the washing of hands, even when you do gather. So we're going to have what we tentatively calling Safe at Home for the Holidays campaign. Upcoming messaging, December messaging will be that, staying home for Christmas. We do think, as you heard at the very beginning of our meeting, that these 2 holiday periods are going to be just really rough times for us, as we like to gather, and we just hope that people will stay safe and wait until it's a more opportune time for us to gather like we typically do. Our messaging in early January will be around the vaccine, and that again is going to be determined by the availability here in Louisiana, vaccinations. And then of course, most of you are aware that Mardi Gras has come under concern for a lot of folks. Several of the cities have canceled parades, and there's still going to be Mardi Gras festivities, no matter if they're parades or not. And so we're going to put together a campaign on how to do it safely, and make sure that people continue to be vigilant. There's no real expectation that by late January, early February, that we'll be past the part of this pandemic that we're in right now. So that wraps up our report. I'd like to open the floor to any of the committee members here who have other bits to share. And if not, then we'll take any questions.
We'll open up for any questions then.
I'd like to make just one quick comment. We can splice the video to take the fallout and just keep the virus related to influenza, because that flu season goes all the way through the spring. People think it's just the fall and the winter, but it goes on. So we should stick with that. And secondly, we should await the leadership to give us direction on when we can talk about the vaccine, start to do that. There's still a lot of discomfort about the safety of the vaccine. That 94%, 95% sounds like a Las Vegas gambler who says they're going to win all the money tonight. So I don't know. But once we get the green light from leadership, we will try to address COVID-19 vaccination.
Okay. Well, Dr. Rivera, as always, it is a pleasure hearing about the work that your subcommittee is doing. You have one of the most funnest meetings to attend. You start with music, you end with music, you really get your task force creativity flowing, and it shows in the products that you all have produced. So we're very appreciative, and the messaging continues. As this coronavirus continues, so does our messaging. So we thank you for that.
Thank you.
Okay, Dr. Levis?
Yes, ma'am.
Update on the National Governors Association.
Sure. And before doing that, I also want to add my thank you to Dr. Rivera's personally for stepping in and chairing this subcommittee, which I started out as the co-chair of, and simply could not manage. And I think that you've done an excellent job and moved that subcommittee much further along than we were able to move, and really got us moving. And I'm really pleased to see how much you've been able to accomplish in the time that you've been in this role. So thank you.
Thank you so much.
The National Governors Association has established a learning collaborative among the various state task forces for COVID-19 and health equity. They reached out to states that have counterpart task forces to this one, and established we had an initial meeting of those task forces, which occurred a week and a half ago. Not much happened at that meeting except for initial introductions, but we talked a bit about what we would try to accomplish with this learning collaborative. And essentially what we want to do is to learn from each other, to share what each task force is doing in each state, what resources have been brought to bear, the way that we're organized, things that we can do to be effective, what's working, what's not working, and also to learn what's happening in other states that we think might be effective in Louisiana. That's pretty much what we have at this point. There'll be meetings going forward. There's not going to be a structured cadence to the meetings. There'll be more periodic, so that's pretty much all we have at this point. But as we meet going forward, and there's reports to bring back to this task force, I'll be bringing them back in the future meetings.
Thank you, Dr. Levies. Ms. Tracy, are there any public comments?
No, ma'am, I have not received any.
Okay, thank you. Well, I thought maybe we would just end with a summary of how far we've come. As you know, we're about 7 months in to serving on this task force. As a whole, the task force is a recommending body. We do not have any legislative authority. Our charge was to make recommendations to the governor, and which we did, and he acknowledged receipt of those recommendations. Now, he has the authority to accept the recommendations, act on them, or not. Some of our short-term recommendations have been implemented. For example, the recommendations that we made on the state testing plan is driving that testing process, with providing over 200,000 testing to at-risk populations. As you heard from Secretary Kimberly Robinson, the Louisiana Resilient Commission just submitted their recommendations to the governor this week. And so the plan is that he will read their recommendations. He will look at our recommendations and give us more feedback to see if there's any synergistic engagement that he would want to recommend coming out of both of those recommendations. There are still subcommittees, as you can see from today, that are still working on their deliverables. The Messaging and Communications Committee is ongoing working. You heard they asked for more money to continue their role with getting messages out. So that committee is continuing to do the work of the task force as it relates to messaging and communications. The Health Equity Dashboard was one of our long-term deliverables, and you can see that the first part, or the first phase of their work, will be forthcoming in December. And then the racial disparities in healthcare under the leadership of Dr. Gee and Dr. Mopin, they are continuing their work, as that is a long-term deliverable as well. So the end date of the work of the task force will be determined once all of the deliverables from the subcommittees are finalized. As you can see, COVID numbers are rising, and so our work is not done. We have the governor's ear, and he is hearing our trusted voices. And so this is where we are. We want to continue with the work that we are doing, and we are appreciative of the meaningful work that you have done and contributed to this committee. Dr. Levice, you have anything? I think that you and I have been talking about where we are, and kind of that's a snapshot of, you know, where we are with the committee's work.
Yeah, I think that's a good wrap up. The only thing I would add is that, you know, you've noticed, I'm sure, that we've modified the cadence of our meetings and that we're not meeting weekly any longer. This is in part because we're still waiting to get more feedback from the governor on the recommendations that we've made. And so we'll be setting up meetings going forward. They'll always be Friday afternoon, but they'll be dependent upon an agenda and whether or not we have sufficient number of reports to provide.
Right. Okay, and he told me to remind you that, you know, he's been dealing with the hurricanes too, so that has had an impact. So on behalf of Dr. Levice and myself, we wish you and your families a very happy Thanksgiving. Be safe. Prayerfully, next year, Thanksgiving will be very, very different from the way it is this year. But stay healthy, and thank you for the meaningful work that you're doing for the state of Louisiana.
Thank you all.
Happy Thanksgiving, everyone.
Okay. Bye-bye.
Bye.
Thanks.